Good morning, everyone. Thank you very much for this very kind invitation to speak in this conference, and I'm very glad to be again here in Kiev. I've been coming to Kiev for many years now, on the average every 6 weeks, I would say. And when they ask me, people, you know, what's going on there, it's, how come you go there? I always tell them, you know, where we live in Haifa, you don't have what we have. We have 40,000 Scud missiles aimed at Haifa from 40 kilometers away. So Kiev is a very, very safe place, believe me. And I hope things will straighten out, and this is a very beautiful country and it deserves good times. So I think we should be optimistic. So, milestones in the evolution of breast cancer. Just shortly, breast cancer has been known for many, many years. From Greek times, this is a Greek statue showing a breast cancer. This time it's on the right side. You can see a very inoperable tumor with skin invasion, with all the signs of an inoperable disease, which has been already known to the Greeks. I didn't know if they know that this is cancer, of course. So until the 1900s, surgery was the treatment of breast cancer. And as you can see, surgery is still an important part of the treatment of breast cancer. Of course, it's a major part. However, it is now being followed by other treatments, and the disease is becoming more systemic, and you will see that the molecular basis is more well understood, and there are other aspects of treatment that have been evolving over the years. This is a slide that I borrowed from Yazid Belkacemi, showing you that 5,000 years ago, they already did surgery on breast. Some of them were breast cancer, some of them were infections, of course, but surgery for breast cancer has been for thousands of years. This is a very new slide. This is only 500 years ago, showing you that breast surgery has been done 500 years ago, but the concepts didn't change. Only the costumes. The costumes are different of the surgeons. This is from 90 years ago at Johns Hopkins, where they did these kind of radical Halsted-style, what we call later mastectomies, with removing everything, because at that time the concept was that breast cancer is an anatomical disease. You should remove and run after the cells until the last cells, so do a very, very radical surgery. And then, of course, the next step in surgery was to change from radical surgery to modified radical mastectomy, less functional effects and less complications after doing this kind of surgery. But I would say that the evolution and the revolution occurred not many years ago, when the Veronese and the Fisher concept arrived into surgery, and radical mastectomy has been replaced by conservation surgery, by the lumpectomy or the quadrantectomy. This was a revolution in the concept of surgery and the concepts of the disease. And you can see here a patient who is 9 years post-radical mastectomy, but then lumpectomy came about. On the other side, you can see on the left side that she has a lumpectomy for the same disease. So just to look at the difference. And as we know, there is no difference whatsoever in the survival probability of patients undergoing surgery, radical surgery versus localized surgery. And of course, we would like to avoid this kind of cosmetic and functional complications and consequences of the radical surgery and the radical radiation. And as you will see, also there is changes in the radiotherapy. And of course, this is a better outcome for a patient with breast cancer, that you hardly can notice which side has been treated by the lumpectomy and the radiation. And of course, the next step in surgery was the avoidance of the axilla by doing the sentinel lymph node sampling, avoiding the surgery to the axilla, which gives a lot of late effects and complications. And these milestones in the development of surgery correlate with the paradigms of breast cancer that have been changed. The natural history and the management of breast cancer have been changing over the years. It started with the anatomical approach of Halsted, you should remove and run after the last cell, went into the other side, the Fisher concept, that you don't care about the local disease, this is not important, you just have to care about the metastatic disease, which is not true, it's only partially true. The real concept is the spectrum concept, that breast cancer is a local disease but also a systemic disease, and the decision should be taking into account these two approaches, the local approach and the systemic approach. So what happened in the field of radiotherapy? Because radiotherapy is another part of the treatment of breast cancer. So you can see here pictures from the beginning of the century. On the very few side, it will be on the left side, you'll see a patient in London in 1903 receiving radiation for a breast, probably cancer. Then a picture from Paris from 1908 where Chicoteau is treating a patient with ultraviolet radiation. He was a painter and a radiologist, and he was treating them with this device, which tells you that radiotherapy has been around for many, many years in breast cancer, and this is brachytherapy done sometimes in the 30s. This is a big picture from 1903, same patient getting the radiation with ultraviolet equipment for breast cancer. And again, and these are the side effects of ultraviolet, it gets a very bad effect on the bones. So we switched to modern technology, modern quotation mark. This is the first, just to show you, this is the first cobalt-60 machine installed in Israel in 1957 in the city of Haifa, in the Italian hospital of Haifa. They were the first to have a cobalt-60 machine, and this machine worked until the early 90s. It's a good machine, cobalt, if you know how to use it. Then it was replaced by more modern machines. But the problem with cobalt-60 is very simple. The haziness of the borders, radiation not very sharp, and of course it has been replaced by the accelerator with more sharp beam, and now with modern technology, modern equipment. But let us put it this way, the photon has not changed for the last 100, probably, and 10 years. Not even the proton. They have been there for more than 100 years. The biology is well understood, I would say. The delivery system have changed, and the concepts, when to use and how to use and which are the volumes that we should irradiate, this has been changed, not the photon. The photon is the same photon for over a century. So this can show you that we can do partial breast radiation and whole breast radiation with very complicated techniques, even proton beams. The biology is the same. And the standard has been radiation to the breast and the lymphatics in 5 weeks with a boost, so the treatment will take 7 weeks. And radiation is very important, not only for the local control. We know from the Oxford overview that radiation also improves the survival of patients treated for breast cancer. And the problem that we can avoid now with the technology is to avoid on left breast side breast cancer, to avoid the heart by using either free breathing techniques for what we call 4D radiotherapy planning, or proton beam. We can then avoid the heart and not affect the longevity of patients by side effects. So the changing in the concepts in the systemic and local regional treatment of breast cancer have been occurring in the last 30 or 40 years, moving from maximal tolerable treatment to minimal effective treatment, and reducing the radiotherapy time by hypofractionation radiotherapy. We can see now the papers coming out showing that if you give the treatment instead of 7 weeks, in 3 to 4 weeks, you get the same control and the same cosmetic effect. And we also move now to reducing the volume of radiotherapy. In special situations, in low-risk cases, we can treat only the tumor site and avoid the rest of the breast, making the treatment short and just treating the volume. There is following work of important studies, such as the study of Veronese, showing that most of the recurrences after lumpectomy occur in the tumor bed. And what are the new things happening now in radiotherapy of breast cancer? That's happening in the last few years. A few studies done in Europe and in North America have shown the importance of treating, and this is in our field, showing that we can extend the survival of patients by treating the lymphatics, and also you can see that there is slight improvement treating the lymphatics, and also we can replace surgery of the axilla in patients with N0 or very minimal disease in the axilla. We can replace radical surgery of the axilla by radiation. So the advantage, and studies called AMAROS done by the European group has shown that if you irradiate axilla instead of doing radical surgery axillary section, you avoid that you reduce the amount of edema in the arm. So maybe it's another step forward with this technology. How about the systemic treatment? A revolution occurred in 1896 when Bitson discovered that he can treat inoperable breast cancer by doing hormonal manipulations. By removing the ovaries, one can induce remissions in breast cancer. And we have seen over the years that by hormonal therapy, in patients with positive receptors, survival can be improved by adding tamoxifen and later on the aromatase inhibitors. Then came the chemotherapy that was used first for metastatic disease, but then in the adjuvant setting, we have been showing that by using the CMF combination, the Bonadonna combination, and then the American combinations, showing that one can improve the prognosis of breast cancer patients by adding adjuvant chemotherapy in young patients, but also in more senior patients. And drugs have been developing, and more modern chemotherapy came out there and improving step by step the survival of patients with breast cancer. Then always I show this graph because when we start to speak about molecular biology, I always think about the Paris actually, metro system, but there is this metro system also in Kiev. Just to show you, it's so similar. Look here, I mean, you compare the metro system and what they show you always on molecular biology. We learn more and more about the signal transduction and all kinds of things happening in the cell that produce the malignant transformation, and then how can we control it, how can we put things. So the HER2 gene, for instance, has been discovered in the 80s. He's been known for more than 30 years now. But it took us 30 years to learn that by adding the Herceptin to HER2 positive patients, we can more than double the median survival from 20 months to 45 months by adding Herceptin to metastatic breast cancer. Then we could show that by adding the Herceptin to HER2 positive patients, we can extend in the adjuvant setting, we also can extend the survival of these patients. So these things are now happening. The addition of and I think that Dr. Grigorov will elaborate on that, how we can improve the care of breast cancer patients, tailoring the new things that we learn from molecular biology. And finally, the decision making. I know that there are many surgeons in the audience. So many years ago, it was the domain of the surgeon to make the decision how to treat a breast cancer patient. Now we know it's a teamwork. Everybody has to be involved. The surgeon, the medical oncologist, radiation oncologist, social workers, plastic surgeon, technologists, molecular biologists, radiologists, everybody, the whole team should be involved in the care. And we have to know the prognostic factors. In the past, the prognostic factors, they dictated the treatment modalities. The tumor size, the lymph node involvement, the grade, the age, the receptor status, the HER2 status. Now with the new era of molecular biology, we have now things that we can check and we can evaluate the genomic profile of the patient and adapt treatment according to the genomic fingerprint of these patients. And you can see that when you use these arrays, you can see that the survival of patients is very much dependent on their genetic profile. So cancer therapy today is eradication of all cells, by surgery, chemotherapy, hormones, radiation, etc. The future will be selective targeted eradication of cancer cells. It will be less toxic, more efficient, and like here, you come to the doctor, he will, according to your profile, give you the right drug, and actually we can already see the reduction of mortality of breast cancer with early detection and using these modern technologies in the care of these cancer patients. So breast cancer should be treated by a multidisciplinary team of experts, and we look forward to improving and to eradicating, actually transforming this disease to a curable, almost 100% curable disease in the near, not too far away future. Thank you very much.